Good afternoon, everyone. Welcome to Yale Sleep Medicine Grand Rounds. My name is Carolyn Cronin. I am a pediatric sleep medicine physician at Norwalk Hospital. I'd like to make a few housekeeping announcements before I introduce today's speaker. Please take a moment to ensure that you are muted. To receive CME credit for attendance, please see the chat room for instructions. You will need to sign up to receive credit. If you have not yet done so, please send a message to Debbie Lovejoy. If you think anyone else would be interested in joining us, please reach out to her as well. I will be moderating today's session. If you have any questions or comments during the presentation, please use the chat room or take the opportunity to unmute yourself at the end of the talk to ask your questions. Recorded versions of these lectures will be available on YouTube a few weeks after the presentation. Okay, so today, without further ado, I have the honor of introducing today's speaker. Today's speaker is Dr. Sana Chaudry. Dr. Chaudry is a graduate of medicine from the American University of Antigua. She then went on to complete her pediatric residency at Nassau University Medical Center, where she received an award for Best Resident. And then we had the pleasure of having her join us at Norwalk Hospital as one of our fellows. So without further ado, take it away, Dr. Chaudry.
Hi, everyone. Hope everyone's having a good day. So today, my presentation, it's titled Not All Twitches Are Trouble. And this is because I'll be talking about pediatric sleep behaviors, and most of it will involve movement disorders that are primarily benign. We know much of medicine consists of reassurance, but this is particularly true in pediatrics and in sleep medicine. Patients are not well informed of what normal sleep is, and they can get worried about a lot of things that we consider benign. So we routinely have to reassure parents on what is normal and when to be worried. So that's why I chose this topic today, and hopefully we can all benefit from it. So the first slide is just a disclosure. I don't have anything to disclose. And then there's also the instructions to get the CME credit. So I'll just leave this up for a few seconds for everyone to see. Okay, and then just to get a little introduction into pediatric sleep, I'll start by just doing a quick review on what healthy sleep duration is. So the American Academy of Sleep recommends you get the following hours of sleep on a regular basis for optimal health at each stage of life. And for kids, we know that's important for development as well. For infants, 4 to 12 months, they recommend 12 to 16 hours of sleep. For toddlers, 1 to 2 years old, they recommend 11 to 14 hours of sleep. For kids 3 to 5 years old, 10 to 13 hours of sleep. And for children 6 to 12 years old, 9 to 12 hours of sleep. For adolescents, 13 to 18 years old, 8 to 10 hours of sleep. And then for adults, it's going to be 7 plus. And just a little outline of what I'll be talking about today. So I will talk about benign sleep myoclonus of infancy. I'll talk about sleep-related rhythmic movement disorder, hypnic jerks, also known as sleep starts, sleep-related bruxism, confusional arousals, somnambulism or sleepwalking, sleep terrors, and nightmare disorder. So the first one will be benign sleep myoclonus of infancy. It's a disorder that's mentioned in the ICSD-3 under the sections of sleep-related movement disorders. And the reason they put it in this section is because it's commonly confused with epilepsy. And then I'll go into how it can be confused with seizures. And then just kind of talk a little bit about the demographics. So prevalence is unknown. The incidence has been estimated at 3.7 per 10,000 live births. More than 200 cases have been described. It has been around for over 40 years, so we do know much about the diagnosis. Males are affected more than females by a ratio of about 2 to 1. And so what is it? It's usually observation. So it has to be seen by the parent, caregiver, or anyone that's watching the baby. Repetitive myoclonic jerks that involve the limbs, trunk, or whole body. The jerks are often bilateral, massive. They typically involve large muscle groups, and they can include the whole body. They rarely include the face, but they can. They occur only during sleep. they occur in early infancy, typically from birth to 6 months of age, and they stop abruptly and consistently when the infant is aroused, and that's going to be an important feature to distinguish it from seizures as well. And of course, it's not better explained by any other disorder. It's usually sporadic, but genetic factors can contribute. There is a genetic component, but we don't fully understand it. They reported some familial cases. There was one study that showed autosomal dominant inheritance, but it didn't show the KCNQ2 and KCNQ3 genes, which are commonly found in the familial neonatal seizures that this disorder is commonly confused with. Pathophysiology is not fully understood, but they do have two hypotheses that have been reported, and I'll go over each hypothesis. So the first question is, where is this myoclonus coming from? Is it coming from the brainstem? Is it coming from the spinal cord? So one study postulated that it is generated in the cervical spinal cord. Another study postulated immature or imbalance of serotonergic system. And the rare presentation of facial involvement is due to immature myelination of the cortical bulbar tract. So normally the cortical bulbar tract is myelinated before the cortical spinal tract, and we see the presentation of the facial involvement in earlier infancy compared to later on. So that kind of is consistent with this hypothesis. One of the studies, which was an 18 series, showed that the mean age of onset was 9.6 days, with a median onset of 7.5 days, and they even had the earliest onset to be reported at 5 hours of age. If it's symmetric, if the myoclonic jerks are symmetric, it's usually easy to diagnose, but then there have been case reports of unilateral and lateralized features, making the diagnosis a little bit more difficult. So the myoclonus jerks are irregular in frequency with 2 to 3 rapid abduction, adduction, bilateral jerks followed by a short pause. And this can be confused with infantile spasms, which also have the abduction, adduction, bilateral jerks. But those will occur during wakefulness, and they usually have pain associated with it. And going to a little bit more of the presentation, as I mentioned earlier, head and facial myoclonus are rare, but 11% in this case series were reported. And we know that the spontaneous or provoked awakening of the infant leads to cessation of the movements, as we saw in the diagnostic criteria. But what was interesting is that simple maneuvers like gentle rocking or maneuvers that we think would actually calm babies down actually provoke the myoclonic jerks in this disorder. And, while this might not be good for parents, because that's the first thing that they're going to do is they're going to go and try to comfort their baby, but it is useful for EEG. So whenever we have patients where we're not able to differentiate between neonatal seizures and benign sleep myoclonus of infancy, we can do the gentle rocking motion to provoke the myoclonic jerks, and then look at the EEG for any epileptiform activity. Another thing is that can worsen or exacerbate these myoclonic jerks is benzodiazepines, and that's something that they learned early on when they thought it was seizures, and they treated it with benzodiazepines, and they saw that it was getting worse, and it kind of mimicked status epilepticus. We also, another differentiating feature is that the restraints don't stop the myoclonic jerks versus in like jitteriness or neonatal withdrawal, opioid withdrawal, where gentle restraints can help with the jitteriness. Here, the restraints will actually make the myoclonic jerks worse. And what are the objective findings that we see in this benign sleep myoclonus of infancy? The main thing is the video PSG, so it is a clinical diagnosis. And when you look at the EEG, it's going to be normal. It's not going to have any ictal or interictal abnormalities, and it occurs predominantly during quiet sleep, but it can also be present during active sleep. The muscle jerks are seen in clusters of 4 or 5 jerks per second, and each jerk lasts about 40 to 300 milliseconds. And the clusters can repeat in regular series for 1 to 15 minutes, and some cases even up to 60 minutes or longer. And then neuroimaging studies will be normal. So here I have a video. You can see what it kind of looks like. So I'll play the video. So you can see it's symmetric. It's occurring bilaterally. It's involving a large muscle group. They're really quick. And so for the differential diagnosis, I kind of talked about infantile spasms. I talked about drug withdrawal. Periodic limb movement disorder can also occur in infants, but it's going to be distinctly different in duration and frequency. The muscle activity is going to be of longer duration of 0.5 to 10 seconds, and it's going to occur at a more regular and longer interval, whereas the myoclonic jerks and benign sleep myoclonus of infancy are going to be more irregular. It can be associated with EEG arousals, whereas the benign sleep myoclonus of infancy is not. And in periodic limb movement disorder, you'll see the movements occur predominantly in the lower limbs or the legs, whereas in the benign sleep myoclonus of infancy, they occur more in the upper arms. And we kind of talked about neonatal seizures as well, but I'll go more into it. And this is kind of a head comparison of the two disorders. We talked a lot about most of these. So benign sleep myoclonus of infancy is going to have myoclonic jerks, whereas neonatal seizures will have more of the tonic-clonic presentation. One of the key distinguishing features is the eye characteristic. So neonatal seizures, the eyes will usually be open, whereas in sleep myoclonus of infancy, their eyes are going to be persistently closed. We talked about how they're provoked. Neonatal seizures are going to occur abruptly, spontaneously. They're going to occur in sleep and wakefulness. And usually benzodiazepines or anti-epileptic drugs are going to end the seizures, whereas they're going to make it worse for myoclonic jerks. The EEG, of course, is going to be normal versus abnormal. And then usually when you have a healthy term infant who's normal neurological exam, they're more likely to have the benign sleep myoclonus of infancy. Whereas if you have an infant with hypoxic ischemic encephalopathy, congenital brain malformation, metabolic disorder, or infection, they're more likely to have neonatal seizures. And the outcome also is going to vary between the two. So the management is basically, when do you reassure and when do you do an EEG? We can't do an EEG in everyone, so we have to really select the patients. And what you're looking for is atypical features. And some of those atypical features include prolonged duration, if it occurs during wakefulness, if there's head and face involvement, if there's consistent focal features. And so you might ask, what is considered prolonged duration? Prolonged duration for a myoclonic jerk is going to be more than 1 to 2 minutes. They typically last seconds to 1 to 2 minutes. So anything that lasts more than that should raise concern. And that's all I have for benign sleep myoclonus of infancy. The next disorder I'll be talking about is sleep-related rhythmic movement disorder. It's repetitive, stereotyped, and rhythmic motor behaviors that also involve large muscle groups. They're going to be predominantly sleep-related, so they occur near nap or bedtime, when the individual appears drowsy or sleep. The behavior has to result in significant complaint as manifested by at least one of the following. So this is important because if there's no clinical consequences of the rhythmic movements, you can't call it a disorder, and then you just note that there were rhythmic movements. So the significant complaint can be interference with normal sleep, significant impairment in daytime function, and self-inflicted bodily injury or likelihood of injury if preventative measures are not used. So that's really important because the self-injury in these disorders can cause alopecia, large skull defects, and subdural hemorrhage. And of course, it's not better explained by another disorder. So going into the demographics for sleep-related rhythmic movement disorder, At 9 months of age, they saw 59% of all infants reported to have at least one of the sleep-related rhythmic movements, 43% of them having the body rocking, as you can see here in picture A, and then 22% of them having the head banging, seen below in picture C, and then you can see in 24% of them had the head rolling as seen in picture E. At 18 months, the overall prevalence decreased all the way to 33%, and by 5 years old, only 5% of them had the sleep-related rhythmic movements. So we know that it definitely gets better with age. It can occur in adolescents and adults. They have 50 cases that they reported where it occurred in adolescents and adults. It's typically going to persist in children with autism spectrum disorder or developmental delay. And it was found to have a male preponderance when it was found in adults. And it's also more common in Down syndrome, where they saw 15% of cases in children with Down syndrome, and also associated with poor sleep quality. So kind of going into the movement semiology, here in the first picture, you see the upper body movement. And it could be with or without head banging against a pillow or mattress. And then picture B is full body movement, and it can occur with and without head banging on the headboard or the wall. So I think that can be very dangerous. And then C, you have the body rocking forward. In D, you have the body rocking backward. In E, you have the head rolling. And then in F, you have the full body rolling. And the most prevalent of these was the upper body movement with and without head banging, followed by the full body movement with and without head banging, followed by the body rolling, and then the head rolling. So I'll show you guys a video of the head rolling. You can see it here. Sorry. Kind of lagging, but I think you guys can see. Sometimes kids with autism will have this repetitive head rolling, but then they would also have it during wakefulness, and it would be mostly occurring during wakefulness and not only during sleep. This is a figure showing a PSG of sleep-related rhythmic movement disorder. Here, they're particularly looking at head banging. So the frequency range for rhythmic movement disorder is 0.5 to 2 hertz with at least 4 defined movements. And you can see that in the, that's going to be considered a cluster in this dashed box. And it's usually separated by a pause, and then it reoccurs. And the amplitude has to be at least 2 times the background EEG activity, the EMG activity as well. And this is more of like a real life example of what the PSG would look like. And again, you see the clusters here. You can see movements. Definitely you have more than 4. You definitely have the 0.5 to 2 hertz in frequency, and you definitely have 2 times more amplitude than the background EEG activity. And then here it occurs again. The pathophysiology is not fully understood as well for this disorders, but there are 2 hypotheses. The first one is the hypothesis of normal development, and this is just basically saying that it coincides with milestones of psychomotor development, that the rhythmic movements, the head shaking or whole body shaking stimulates the vestibular system, and that positively affects motor development in infants. The second one is self-soothing learning behavior. And the way they came up with this is because the disorder was initially thought to only occur during wakefulness or during sleep-wake transition. So they kind of saw it as a sleep onset association, where kids will kind of do these behaviors to soothe themselves and put themselves to sleep. But now we know that it occurs in all sleep stages, including REM sleep, which is not really consistent with this hypothesis anymore. They believe that the rocking movements mimic the maternal movement, the heartbeat and respiration in utero. And they also had studies where they showed it was associated with lower maternal sensitivity, which they measured by observing the accuracy and appropriateness of mother's response to the infant's needs. There has been reports of monozygotic triplets and monozygotic twins, but the genetic basis is not fully understood. There has been case reports showing multi-generational families with sleep-related rhythmic movement disorder and insomnia as well. But again, not fully understood. For the treatment, we also lack randomized controlled trials, but there have been clinical reports on hypnosis, benzodiazepines, melatonin, sleep restriction, and CBT. The ASM recognizes that the treatment is usually not necessary in most cases, but it's indicated when the movements cause injury, significant sleep disruption, or daytime impairment. And ideally, you want to go with the behavioral approaches first, including immediate feedback, reward system, and aversion therapy, which is described in a small number of cases and showed improvement. For pharmacological therapy, they did come up with clonazepam. It's not FDA approved for treatment of this disorder, but is used off-label, and it's because they have shown it being successful in treatment for adults with rhythmic movement disorder, and in some reports it was successful in treatment in children with Fragile X as well. And of course, if they have any kind of comorbidities like OSA, you want to treat that. Treating the OSA has also been shown to resolve the sleep-related rhythmic movement disorders. And one of the biggest or the most important intervention for this disorder is safety intervention. You want to focus on injury prevention. So you can add bed padding, use bed drills and safety helmets like the one seen here, and confirm the stability of the patient's bed. So then that's all I have for sleep-related rhythmic movement disorder. And next I'll be talking about hypnic jerks or sleep starts. These are benign movements, particularly at sleep onset, but also during arousal from sleep. The jerks consist of asymmetric, single myoclonic extremity movements. They're usually associated with tachycardia, tachypnea, and reported sensation of shock or falling. So the motor activity is often associated with a sensory component. The sensory component could be like an impression of falling, or less commonly pain, tingling. It can also be auditory sometimes with banging, snapping, or crackling noises. It can sometimes even be visual, where you see flashing lights, hypnagogic dreams, or hallucinations, and sometimes even a sharp cry might occur. They're triggered by environmental factors, which includes fatigue, stress, sleep deprivation, exercise, and caffeine. The jerks rarely become frequent enough to cause insomnia, but they definitely can. The pathophysiology is uncertain, but they did report a prevalence of 60 to 70%, so it's pretty common. It was highly sporadic. The sleep starts affect all ages and both sexes, and a lot of times patients won't recall a jerk, but it'll be noted by their bed partner because a lot of times they won't cause awakenings. And here's an example of a hypnic jerk, so you can see there, and I'll just let it play one more time. So this is a figure of a PSG of a patient with hypnic jerks. The PSG monitoring has shown that hypnic jerks usually occur during transitions from wakefulness to sleep, and mainly at the beginning of the sleep episode. So the EEG is typically going to show N1 sleep. They're going to occur during N1 sleep, and they sometimes might start initially with a negative vertex sharp wave occurring at the time of the jerk, and then it's going to show brief high amplitude potentials as seen here. They can either be single or in succession. They're generally 75 milliseconds to 250 milliseconds long. And then you can see the autonomic activation with it, sometimes with the tachycardia, tachypnea, irregular breathing patterns. And then after the jerk, you might see a brief arousal or return to sustained wakefulness. Although PSG is usually not needed for hypnic jerks, it's again a clinical diagnosis, but sometimes if it's causing insomnia, you might need to do a PSG, or if it's causing frequent movements. The next disorder I'll be talking about is sleep-related bruxism, and this is going to be regular or frequent tooth grinding sounds occurring during sleep, and you'll have the presence of one or more of the following clinical signs. So you have abnormal tooth wear consistent with reports of tooth grinding during sleep, transient morning jaw muscle pain or fatigue, temporal headache, jaw locking upon awakening, consistent with the tooth grinding reports during sleep. So it was found to have a positive association with a lot of things. It was found to have a positive association with genetics, quality of life aspects, so school and emotional functions, and overuse of screen time. And that just, there you go, just one more negative thing that's associated with increased screen time. Mother anxiety and family conformation, diet, so things like caffeine from sodas and chocolates, high sugar diets have shown to increase bruxism in kids, alterations in sleep behaviors and architecture, so any kind of sleep deprivation, and of course, sleep breathing disorders also will increase the bruxism in these patients. This is showing just the epic of a PSG with bruxism. You can just see it in the chin EMG. A lot of times it can be associated with arousals each time. And next I'll be talking about the disorders of arousals or non-REM parasomnias. I'll be typically talking about three, confusional arousals, sleepwalking, and night terrors. So disorders of arousals, they consist of complex behaviors. They're usually initiated during slow wave or N3 sleep. So you might ask why non-REM parasomnia is more common in children. There's more N3 or deep sleep in children. So the general diagnostic criteria for all the disorders of arousal is listed here. So recurrent episodes of incomplete awakening from sleep, inappropriate or absent responsiveness to efforts of others to intervene or redirect the person during the episode, limited or no associated cognition or dream imagery, partial or complete amnesia for the event, and of course, it's not better explained by another sleep disorder. The events usually occur during the first third of the night. The individuals may continue to appear confused and disoriented for several minutes or longer after the episode. And so the behavioral semiology. So in sleep terrors, they're going to be very distressed. You're going to have a lot of prominent autonomic activity. You're going to have the mydriasis, tachycardia, tachypnea, diaphoresis. That's all going to be present during the sleep terrors, and you can have variable motor activity. So sometimes the child just might be lying there. Sometimes they're sitting up. Whereas in sleepwalking, it's the opposite. You won't have any of that distressed behavior. It's going to be non-agitated motor behavior, and you won't have any of the autonomic signs, no tachycardia, no tachypnea. And then confusional arousals, you have neither. You don't have the distressed child, you don't have the non-agitated motor behavior. It's usually going to last 1 to 10 minutes for each of these things. Start with confusional arousals. Of course, it meets the general criteria that we just discussed. The episodes are going to be characterized by mental confusion or confused behavior that occurs while the patient is in bed. So is in bed is important because once they get up and leave the bed, it's going to become sleepwalking or somnambulism. And so that's the next diagnostic criteria listed here. So sleepwalking. Occurs in approximately 15% of children, peaking between age 8 and 12 years. Mild episodes may initially go unnoticed. So mild episodes could be like a toddler that sits up and crawls around the bed, or walks up quietly and kind of stands by the parent's bed. And so I had a patient recently who, she's about 9 years old, and the parents were saying how she walks into their room every night, and they kind of took it as she wants to come and sleep in their bed and kind of can't sleep without sleeping in their room. But it turned out that she was actually sleepwalking into their room. She wouldn't remember the events. So it can be very mild in those instances, but then other children, they might become agitated, run around the house, or have confused, inappropriate behaviors. Some patients have injured themselves. So sometimes kids will walk out in like cold wintry nights. They'll induce hypothermia. So it can be dangerous in that sense. And autonomic dysfunction can coexist in the form of sweating and flushing of the face, but typically you don't see a lot of autonomic dysfunction and sleepwalking. And a lot of these disorders you guys may have experienced or know someone who has experienced them. And I think that makes it all the more reason to talk about these disorders. Often they're overlooked due to their benign nature. So I'm just going to share an incident with you guys, an experience that I had when my brother was sleepwalking. And I think this is particularly interesting. So we were both kind of in elementary school, and it was the middle of the night, and he had walked out of his bed, out of his room to the outside door, and he was unlocking the door that's leaving our house. And I had woken up at the same time, luckily, to use the bathroom. And I see him unlocking the door. And I'm like, what are you doing? Where are you going? And he says, I'm going to the store. And I said, what are you going to the store for at this time? The store is closed. And he said, I'm going to buy candy. And he was actually actively unlocking the door and about to leave until I saw him. So we kind of just, laughed about it the next day. He didn't remember it, and it was just kind of overlooked. So a lot of times these disorders can be overlooked, but now looking back, I'm like, what if he actually went outside and we lived on a busy street and he was just a kid sleepwalking and something dangerous could have really happened. So I think it's really important to educate patients about these disorders and the dangers that they impose. And some patients can have a combination of sleep terrors and sleepwalking, although one type may predominate. So sleep terrors, their arousals characterized by episodes of abrupt terror, typically beginning with an alarming vocalization, such as a frightening scream. Most episodes are brief. They can last about 10 minutes, but then they can go up to 30 to 40 minutes in some children. There is intense fear and signs of autonomic arousal, including the dilated pupils, tachycardia, tachypnea, diaphoresis, as I mentioned earlier. And their eyes are usually wide open, and they typically refer to them as a confused, glassy stare. They're very difficult to awaken, and if they're awakened, they're typically confused. It occurs between 4 and 12 years of age and has a strong genetic predisposition. So you'll see it in brothers and sisters, a lot of times in families. And this is just kind of comparing the three disorders. So for confusional or arousals, you don't have distress, you don't have the non-agitated motor behavior. But with sleep terrors, you start with the intense autonomic discharge. It just starts with that, and then it kind of goes down over time. In somnambulism, you just have the non-agitated motor behavior, and then sometimes you can have hybrid attacks where you have a combination of the sleepwalking and the sleep terrors as well. And here's an example of a sleep terror, and I'll tell you, this is the least scary video I found. Most of the videos, the kid is sitting up, crying, the parents are crying, they're attempting to console the kid, but it's just unconsolable crying. So imagine this going on for 20 minutes as a parent, so we can see how scary it can be for them. And you can kind of see the glassy stare in this kid's eyes as well. And so just to briefly talk about nightmares as well, I feel like you can't talk about sleep terrors without talking about nightmare disorder as well. So nightmares you will remember, sleep terrors you won't. You'll have amnesia for the event. And we kind of talked about the typical features for sleep terrors. They occur in non-REM sleep, more likely to occur in the first third of the night, which is the opposite for nightmare disorders. They'll occur in the second half of the major sleep episode. They'll have vivid story-like pictures, very dysphoric. They're gonna have fear, they can have anger, disgust, sadness. All of these things can occur. They have autonomic changes in the nightmare disorder as well, but they're going to be more mild. So you might see a little bit of diaphoresis, you might see a little bit of tachypnea, but nowhere near the autonomic changes in sleep terrors. The distress is a lot more in sleep terrors, as we saw in the video. And just kind of summarize the disorders of arousal and review some of their shared characteristics. So they share similar or genetic familial patterns. They share similar pathophysiology of partial arousals from slow wave sleep. They all are worse with sleep deprivation and psychosocial stressors. They're associated with absent or minimal cognitive functioning during the episode and generally associated with amnesia for the prior episode. So one common myth is that the disorders of arousal are secondary to psychiatric disorders. So that's not the case. They're not secondary to psychiatric disorders. So I just put that there. And then universal treatment options. So for all of them, you want environmental safety. For all of them, you want scheduled anticipatory awakenings, and those are considered first-line non-pharmacological treatment in children with frequent predictable events. So a lot of times, if you know that your child has a night terror every night at 2 a.m., you can do the scheduled awakening very easily. But sometimes the events will be unpredictable. One night he has it at 1 a.m., the other night he has it at 3 a.m., and then it can be a little bit more difficult to do the scheduled awakenings. The studies did show it reduced or eliminated episode in most children in 1 to 2 weeks. So it works well. And parents should really not try to wake the child during the episode. It's going to prolong the confusion. And most children don't require medical treatment, and emphasis is on the behavioral management, reassurance, and education. So you can see treatment for all of them is reassure of the benign nature. For sleep terrors, they have relaxation therapy, hypnosis, autogenic training, and psychotherapy. And for all of them, you want to avoid precipitants like sleep deprivation. For confusional arousals, they can also be worse with CNS depressants. For sleepwalking, it can get worse with lithium or non-benzo receptor agonists. For sleep terrors, just the main thing is a lot of behavioral management. So these pharmacological drugs listed here, they're not FDA approved. They're used off labels, so they're listed here, and the common theme is really clonazepam through all of them. And the sleep terrors typically resolve spontaneously as you get older. And these are my references. So now I will take any questions, or if anyone has any experiences with any of these disorders or with any of these patients, if they would like to share that as well.
Thank you. That was a really excellent review.
Thank you.
Let's see if there are any questions in the chat. If anybody would like to unmute themselves, feel free to ask any questions, or if you have any comments.
So I will go ahead and get started. Ian Weir from Norwalk, and fantastic talk. Really appreciate it. Excellent. And your co-fellow Remus had excellent presentation as well. So I think if you've been in sleep medicine long enough, especially if you are seeing pediatrics, you're going to see all of these things that you mentioned. So it's really important to kind of understand this and know when you need to kind of get further testing and whether you need to just give reassurance. Just a couple little things I've seen. The sleepwalking is always we see them in adults as well. Majority of kids who sleepwalk will not sleepwalk as an adult, but about 5% will continue to sleepwalk as an adult. And they can have really dangerous behaviors. And as you mentioned, leaving the house is really a concern. One of the things I tell patients to consider, especially if there's some, like what happened with your brother, if this happened on a regular basis, is there's like what's called a door alarm or hotel alarm. It's like a little thing that goes over the knob of a door handle. And it's really meant to, like, when someone's trying to get out, it makes a noise. It's not meant to wake the person up. It's not meant to keep them in that house. It's really meant to alert, the parents or anybody who's there that the person is trying to leave the house. And then, as you mentioned, you don't really want to wake them up abruptly. You want to kind of guide them back to the bed. But unfortunately, there's been cases of people leaving the house, driving cars, falling out of windows and all these type of things. So that's always an important thing. And then definitely the emphasis on sleep deprivation and getting adequate sleep and good sleep hygiene. That's certainly like the principles of treatment. And then one other interesting thing about the hypnic jerks, I've had 2 patients now that had severe hypnic jerks that was causing insomnia. And it was really pronounced. It would happen every time they went to sleep, and it was very distressing. They were adult patients, they weren't kids. And it was causing really symptoms. And we tried clonazepam. Clonazepam didn't work. And this was a couple of years ago, and I got the fellows, and we kind of did a literature search, and we found that there is some association of SSRIs with the onset of severe hypnic jerks. And the patient was on an SSRI, and then we weaned them off of the SSRI, and the hypnic jerks went away. And that was a number of years ago. And since that time, there's been some case series about that. So just something to consider if you run into that, really a rare condition. But yeah, fantastic presentation, and appreciate it.
Thank you.
I don't see any questions here in the chat. If there's anybody else who would like to unmute themselves that have any questions or any comments or any personal experiences that they'd like to share, feel free to go ahead and unmute yourselves.
Hi, this is Dan McNally. I'll just share the example of a patient I saw first at 57 with night terrors. And she responded well to clonazepam. Part of what makes it memorable is that her husband, who had been suffering through these episodes of abrupt awakenings with screaming, his comment was, "I wish her family had told me about this years earlier." It had really been a traumatic thing for everybody with poor sleep. Nicely enough, clonazepam did a good job and reduced her episodes very well. So I think it's something that's worth considering in adults when they have unusual behaviors.
Yeah, it's too bad, they didn't mention it earlier, because she could have had a lot more years of not bothering her, her family and her bed partner there. But it's good that it helped as she was older. Thank you for sharing. Is there anybody else who has any other comments or questions for our speaker here today? Okay. Well, it was an excellent presentation. And I guess if there are no more comments or questions, we can finish up a little bit early today. And thank you very much. It was a great review.
Thank you, everyone, for listening.
Thank you. I hope everyone has a good day.